HKL team ready?
Hi, Prof. Danina here. Sorry, give us some time. We are trying to resolve our internet connection.
Okay. All right. Please.
Okay, sorry, everyone.
Please try. No, always got technical problem. Don't worry. Yes, I can. I can view the slide already.
Good afternoon, Prof. and fellow colleagues. So today actually I'll be presenting a case from HKL, and it's an interesting case of marrow infiltration by large B-cell lymphoma. Before I start, I would just like to apologize for the technical hiccups that we had a while ago. Hopefully it'll be a smooth journey. Okay. So our first case today is a case of a 69 years old Malay gentleman who had underlying diabetes mellitus, hypertension, and recently diagnosed with papillary thyroid carcinoma. And he was noted to have persistent pancytopenia. Clinically, there was no organomegaly. So the bone marrow aspiration at this juncture was done to further investigate the cause of pancytopenia. So his investigations at presentation, his full gut count, total white was 1.2, hemoglobin was moderate anemia 7.6, RBC was 2.7, platelet was 65, ANC was 0.81.
Any idea about the lymphocytes count?
Absolute lymphocyte count was 0.62 and absolute monocyte count was 0.29.
So it's within your normal range, or is it lower?
It's low.
Lymphocyte count is lower. Lymphopenia.
Yeah.
Okay.
So actually prior to proceeding with BMA, this patient actually had several FDP because he was initially admitted, and during the course of his admission, he was actually diagnosed with the thyroid CA. So one of the FDP actually had presence of red cell agglutination with moderate anemia. However, at that point of time, only bilirubin was available as part of the hemolytic workup, and it was actually within the normal range. Subsequently, the cytopenias worsened, and hence bone marrow examination was actually suggested for this patient. So the first FDP we are seeing now is going to be the FDP that accompanied the bone marrow aspiration.
Was a Coombs test being done for the red cell agglutination?
We did suggest, but it was not done. It was not further investigated.
I see. Okay. But if it is ordinary slide, if there are red cell agglutination, most likely is maybe a concomitant cold autoimmune hemolytic anemia. Yeah. Okay.
Okay, so I will just show the FBP first.
a bit dark. Is it possible to give more light?
Keluar balik.
So, so actually, when you look at the red cell morphology,
Low power looks like ruler formation.
she has a thicker side, Prof. Actually, in the thinner side,
Oh,
you just
okay.
see it's tend to be normochromic, normocytic, and then there's few teardrop cells occasionally. Then
Cannot see. Oh.
there's an NRBC there actually. A mutated red cell. So actually, I'm trying to look for a myelocyte because it's a leukoerythroblastic blood film.
Okay, that is a very important observation in the peripheral blood, indicating bone marrow infiltration, especially he has got a history of papillary carcinoma of the thyroid. Was he receiving any radiotherapy or chemotherapy?
At this point, no.
Oh, okay.
At this point, no.
At least we know that the pancytopenia is due to radiation or chemotherapy. Cannot find the myelocyte.
Sorry, I did mark it actually. So there was a myelocyte, and so actually it's a LE picture now.
Okay.
Probably.
We believe you lah. Never mind lah. So sometimes very hard to find when you got severe pancytopenia. Okay, so just now we saw the nucleated red cell, so presumably there's some myelocytes. So leukoerythroblastic anemia is certainly very serious pancytopenia, thinking of bone marrow infiltration. How old is the patient? I forgot, 60 something.
Yeah, he is 68 years old.
68, yeah. Okay, so very serious problem.
Okay. So subsequently, I'm going to show his bone marrow aspirate.
Okay.
However, it was a dry tap aspirate, so we only have the trephine roll,
Oh,
the trephine imprint. So mainly, if you look at the trephine imprint, what they're composed of, there are granulocyte precursors.
the imprint will be very good if there is any metastatic infiltration.
Yeah, but what we see generally is granulocyte precursors. There's multiple ruptured cells. There are occasional lymphocytes, and we do see quite a number of erythroid precursors actually.
Mm.
Petrifying ring.
Okay.
Focus on one so that you can see clearly.
Yeah. Pretty good, huh? The imprint can see like a smear, something like
Yeah.
good.
Yeah. The interesting part when we look at these erythroid precursors that are present in this trephine imprint, they are mainly the early precursors, the pro-erythroblasts.
Mm.
More of the early precursors is what we actually see, which is something that actually why I'm highlighting at this juncture is because it's something that we would can kind of correlate later and understand why we are seeing this morphology.
Mm.
So otherwise, outright to say an infiltration or a clump, we are unable to appreciate it from the defined imprint at this moment.
Okay. Take a note.
So then we look into the H&E of our define. So at this point of time, we have a patient which is cytopenic and we do not have an aspirate. So hence we do not have a sample for immunophenotyping. And so the only thing that we have next to actually come up with the diagnosis will be our trephine.
Okay. So it's very important now, the trephine.
Okay. So thankfully for this patient, the trephine was a very good trephine. It's a long core with ample of marrow spaces. There are two cores with ample marrow spaces. Okay, so this is actually a low power view. And from this low power view, we can see that for a 68 years old, it's appearing to be hypercellular, and also we have areas of nodular infiltrates.
Mm. Actually, there's also osteopenia. The bony trabeculae are actually areas which are actually very thin out. Not many fat cells, huh?
Yeah. So I will just concentrate on from this view because I want to show actually what from the H&E that we generally would tend to make up at this moment without any IHC. So we can see that there are areas of nodules, and these nodules actually, when you go to higher power, they are mainly composed of small lymphocytes, you can see generally.
Yep.
They are composed of small lymphocytes, but when we take a look closely, I'll just use the pointer here, we also notice there are larger cells.
Yep.
Like this. And we also notice that in this infiltrate, there are quite a number of another large cell here. There are also a number of like other reactive cells that we can see quite a number of histiocytes and actually even plasma cells.
Yes.
So
definitely, this is not a normal lymphoid follicle that we may see in old people sometimes. Yeah. Abnormal. Something there's an abnormal lymphoid aggregates. Okay. Agreed.
So the other feature that we also notice in this find would be
You think there are fibroblasts?
yes, there's also fibrosis, and as well there are actually other cells, and there are other clusters of like immature looking cells which tend to be big
Mm.
and very vesicular. Let's find another area to demonstrate it better.
Is there a pattern, this kind of lymphoid infiltrate? Is it just follicular or is it paratrabecular?
Predominantly tend to be nodular, but there are areas of of paratrabecular infiltration and also subtle interstitial. So there is a mixture of
Mixture,
pattern
yeah. Okay.
of infiltrate, but dominantly when you look at low power, it tends to be nodular.
Nodular. Okay.
So there are areas of these large infiltrate, like sheets of infiltrating cells. And they appreciate they are immature looking cells and they are in sheets actually. And they tend to have prominent nucleoli. So they actually are, this is a very good area.
Yeah, we can see all these large cells with prominent nucleoli. Okay.
Yes. So now we are seeing so in total, these are the two main broad pathology area that we have actually identified in this fine biopsy. So at this point, we also were informed that this patient actually had a lymph node biopsy done. And from the lymph node biopsy, from the linguinal lymph node biopsy, it was actually diagnosed as a diffuse B-cell lymphoma.
Okay. But interesting thing is that the cells that you are looking at, all these famous staining type of large cell with nucleoli, they doesn't look like carcinoma, isn't it?
Yeah, they don't look like carcinoma, Prof. As well as they don't have that typical infiltration that you expect in a B-cell lymphoma, like in clusters. We only see like one, and those nodules tend to actually have a mixture. Actually, we saw like scattered large cells. We saw an inflammatory background, and we also saw multiple small mature looking lymphocytes. So this is the pattern that we are seeing right now in the find.
Yeah. Okay.
So I have the denote here with me. It's HNE. Unfortunately, our lymphoid consultant was not able to be actually able to join us today to actually show us the lymph node. So I will do my best to show the HNE alone, so that actually we could have a correlation of what we are going to discuss further on here.
Okay, good to show. See whether they look similar cells.
So this is the lymph node biopsy.
Not an intact lymph node.
No, it's just strips of lymph node.
I was surprised. Inguinal nodes would be quite superficial, can easily obtain one big one. Okay.
So here, okay, so roughly in the lymph node, you can see the entire architecture of the lymph node is effaced out, the normal architecture. And you see that most of the cells actually that we are looking at now, within the lymph node is all actually neoplastic lymphoid cells. So they tend to be very pleomorphic, and they have like prominent nucleoli. And we look at it, mitotic figures also are quite brisk.
But also got a population of small lymphoid cells.
Maybe those cells are centered nearer towards the vessel, but generally the entire lymph node is composed of these pleomorphic looking cells. But when we look at it closely, this is how in the morphology of it is.
Yeah.
So it actually
You can see the
diffusing.
prominent nucleoli, isn't it?
Yeah. So it's when you compare this with what we saw in the dictionary, I think it's not really the same morphology. So I'll just go back now and show the IHC that we have done on the fine. Start with the CD20. This is the CD20 on the fine. So we can see there is actually a mixture. There are some cells which are large, strongly staining CD20, and also there are some smaller cells. But mainly the distribution of CD20 is scattered rather than in sheets or in clusters. And they tend to be confined within the lymph node, the lymphoid nodules that we saw earlier, because you can see that there's a mixture of the scattered large cells and smaller CD220 expression, and there's a background of small mature lymphocytes at the background, which are not staining with the CD20 actually. So that's one marker that we did for B cell. And then subsequently we did another marker, CD79 alpha.
Okay. Just now the CD20 is a surface marker. 79 alpha is a cytoplasmic. Let's see whether you can see more. Not coming through.
Sorry, Prof, we're having some technical problems.
Okay.
I'm unable to show CD79 alpha due to technical issues, but we have PAX5, so I will proceed with showing PAX5.
Okay. Is it because the slide is shown the other way around? Because it can't focus, right?
Yeah. Actually, the slide cracked, so that's why we couldn't focus.
Oh, this is specs 5.
Focus it all, okay? Focus it all. This way it's not. Focus it all. And this like. Wait a second. Just hold on, Prof. We're having a technical issue.
Unable to focus. Coming. Miss already. Or you're going to magnify it. Yeah, I can see tissue coming up. Low power view.
Yeah, low power waveform. So you can see within the follicle, this is PAX5, and we can see it's actually strongly positive. And we can see that there are larger cells as well as smaller cells that are positive, but the intensity between the larger cells and the smaller cells are same.
Yeah. Distribution, something like CD20 also lah.
Yes, yes. So this is the higher power view.
Not many, yeah.
Yes, but they are confined within the follicle the nodules that we saw earlier.
Yeah.
So subsequently, I did CD30 because there were a lot of large cells which are actually pink positive.
Yeah, tissue coming up. CD30.
Yeah, so the CD30 is actually positive actually, those large cells that we saw. So they are positive. So subsequently we did CD15.
This will be tricky.
Yeah, but
on the large cells.
yes, because generally what the cells that we are seeing is actually maybe the glands that are pent up. But within the follicles, actually, all those cells are actually the large cells that we are seeing within the nodules are actually CD15 negative.
CD15 negative, huh?
Yeah, they're negative.
Okay, right.
They are CD30 positive, but they are CD15 negative.
Fine.
And subsequently, we did MUM1 because the initial DLBCL original tissue for diagnosis of the lymph node was MUM1 positive. So So to demonstrate whether those are the cells, similar cells that we're actually seeing in dystrophy. So the MAM1 is actually positive in those large cells.
Okay.
So did CD10 because it was a non-GCP type of DLBCL. So this CD10 CD10 is actually negative in all those nodules.
What happened to CD3?
Yes, next we actually also did CD3. The distribution of CD3 is actually lot of CD3 positive small cells in the lymphoid, in the biopsy, and they are actually scattered predominantly in a nodular fashion as well. The CD3 positive cells are also, we also did another T cell marker, which is CD5. And CD5 also is predominantly positive and concentrating in the nodular fashion.
Are the large cell positive for CD5?
The large cells are not positive for CD5 but and CD3. However,
More subset of CD3.
However, the cells surrounding them, the small lymphocytes, the small mature looking lymphocytes are mainly T cells because they're positive of CD3 and CD5.
Okay. But not as intense like CD3 lah.
Sorry, bro?
There are more cells, the small lymphocytes, there are more CD3 positive cell rather than CD5, right?
Yes.
Yeah.
So subsequently, also did to actually exclude the possibility of whether, because we did see but mainly whatever cell I see this now we did at this moment are actually mainly concentrating in the cells that are involving within the nodules. So what about the other cells, the sheets of the other cells that we saw actually, they are not actually picking up any of the stains that I showed this now actually. So now actually we have to find out what exactly are those cells because the patient has another pathology as well, which is the papillary thyroid CA. So did the NCK and cytoperi. Which is actually negative.
This one is what? Cytoskeleton?
Yes, Prof.
Oh,
cytokeratin.
Okay. Fine.
And also we did TTF1, which is the most specific marker for thyroid.
Yeah.
also negative.
Mm. Any macrophage stain now?
CD68.
You did, huh?
Yes, we did. There's quite a lot of background stain in CD68. However,
Yeah. A lot. Not sure whether it's background or actually they are actually staining out a lot of histiocytes.
there are some there are staining of histiocyte, but also there's quite a number of background.
Yeah. The control stain is also working very well like this, isn't it?
Yeah.
Yeah. It looks like there are quite a lot of macrophages.
So just to be sure what exactly those cells which I'm actually seeing as diffuse sheets, I also did e-cadering. This is e-cadering actually. So actually all those cells that we saw in sheets and in clusters were actually all early precursors of erythroid.
What stain is this one?
E-cadering.
This one is for erythroid.
Early for erythroid precursors.
Oh, okay.
So actually all those cells are actually erythroid precursors. So at this point of time, the final diagnosis that was concluded is narrow infiltration by the underlying high-grade B-cell lymphoma. And those sheets of cells that we are seeing in the background, they are actually erythroid hyperplasia. And given the history of red cell agglutination in this patient, most probably it's associated with likely there was a hemolytic anemia in the background.
The only thing we can say is that the cell distribution doesn't fit into those typical lymphoma proliferation. Yeah. So it's a very typical presentation. And even though even the distribution pattern also not only got focal, but also, nodular, but also, diffuse. Yeah, it's actually doesn't the usual way it is a lymphoma infiltration. I wonder why lah. Yeah.
So coming up to the discussion of this case, so as we just a brief overview. So B-cell lymphoma, the second DLBCL actually is the second most common lymphoma to involve the bone marrow. The commonest would be follicular lymphoma. So the morphology of cells tend to be variable, pleomorphic, and mixed with cells which are multi-lobated and large cleft nuclei. Like actually, if we see in this case, if we look at it again, it's actually quite large, multi-lobated and large cleft cells are actually present. And then the infiltration pattern, as what Prof mentioned, tends to be more, we tend to expect more of a random focal, paratrabecular or diffuse, and we think that we tend to expect more of a clustering of those abnormal cells. But in this case, it actually appears to be very scattered in nature. Another thing is when we actually did the CD30 staining, actually was positive. So at that juncture, the differential diagnosis actually that we would need to consider is whether this is a Hodgkin lymphoma. And also, if we notice that this patient had nodular infiltrate, and the nodular infiltrate actually composed mainly of T cells, and also there was histiocyte in the background. So another differential will be the T cell histiocyte-rich B cell lymphoma. So these are the three main categories that we actually of differentials that we can actually consider in this patient. However, this patient actually had a lymph node biopsy already with the preempt diagnosis, so we were actually more tailored towards the diagnosis. But in case that we actually get the triphyline without actually lymph node biopsy, and we are seeing this morphological picture, then we would need to actually go through this pre-differential diagnosis. So T cell histiocyte-rich large B cell lymphoma will be one of it. And why is it unlikely in this case? Because we did see that in the background there was a mixture of small B cells as well as larger CD20s and staining B cells. So usually in this entity, you would not see those small mature B cells at the background as well. So hence this patient actually favors more of a DLBCL. And can CD30 be positive in a DLBCL? Yes, in 20% of cases, they can actually be positive for CD30. And it's important also to do EBER test. And why we actually have to do EBER is because if the patient is actually EBER positive, and then we have to redesignate the diagnosis as EBER positive DLBCL. And the third differential would be the Hodgkin's lymphoma, the CD30 positive with a reactive background of histiocytes and like what we are seeing in this case, and also with fibrosis, we would definitely need to actually exclude Hodgkin lymphoma. However, the CD15 in this case was actually negative, and PAX5 was strong. And in Hodgkin lymphoma, we expect a weak PAX5. So just to actually put in a picture of what a large cell Hodgkin lymphoma would look like, actually looks very similar to actually what we see in this biopsy actually. So as I mentioned earlier, there was actually erythroid hyperplasia as well, the bone marrow finding, and that could be actually attributed to the episodes of red cell agglutination that the patient had. So the current progress of this patient, the patient was actually, because there was actually a dual pathology, the plan was to actually treat the patient for his underlying DLBCL. However, patient was readmitted back on the 14th of July, and due to complaints of less responsiveness at home. So he's currently being intubated on single inotrope and powered for meningitis. So the current diagnosis would actually to exclude CNS infiltration of the lymphoma. That's all for my first case today. Thank you.
Okay, yeah. There is a question, Dr. Mazia. Did you do a KI 67?
Yes, we did do a KI 67, but KI is a bit difficult to be interpreted with a background of hematopoietic cell. But I will show it as well. So I think you can see those cells, the large cells are actually strongly positive for KI as well, but I'm unable to quantitate further because it's scattered. So I can't give you a exact percentage cutoff.
Maybe it's actually reflecting the erythroid component. There's the one that's actively dividing. But I suppose if you look at the large cells, probably not that. Anyway, can we invite any comment? Do you think you are agreeable? This is actually consistent with a lymph node biopsy. It is actually the lymph node infiltration of diffuse large cell lymphoma. The only thing is very atypical is the large cells is all single cells rather than aggregate, which is not the usual way they infiltrate.
Can we still call it diffuse, Prof, since it's not diffuse?
It's diffuse because it's actually because lymph node biopsy. So it fits the lymph node biopsy picture, but when it comes to the bone marrow, it's a very
So I mean, if you want to report the trifine, can you still say it's a diffuse, or can we just say large infiltration by large B-cell lymphoma?
There is lymphoma infiltration of the bone marrow. Yeah. And then as described in the pattern that in the report. So it's essentially in the bone marrow diagnosis, you probably say there is a large cell lymphoma infiltrating the bone marrow. You can't exactly classify the types because most of the classification are like the types, including the so-called T-cell rich, histiocytic rich B-cell lymphoma is all based on lymph nodes. You see? So the only way we can say is that there is evidence to support your with correlation of clinical data and also the lymph node biopsy, and then because they carry the same features like the cells you find in the bone marrow. Bone marrow and the lymph nodes are similar in terms of immunohistochemical markers. Then you conclude that this is actually a lymphoma infiltrating the bone marrow. Yeah.
I have a question, Prof.
Yeah. Yes.
But by looking at the KI67 just now, in which you confused whether is it erythroid or is it lymphoid?
Yeah. They want.
Can you still say it high grade or you don't comment?
I don't think you need to comment. Yeah.
So no need to mention high grade. So just large B cell.
Yeah, it's a high grade lymphoma. Any other comment? It's a sharing session, so if you feel anything, you can actually always express your opinion. All right. If not, then thank you, Dr. Chitra, for bringing out an interesting case, unusual in presentation in the bone marrow, probably complicated with underlying history of a co-autoimmune hemolytic anemia, although it's not evident in the peripheral blood.
Thank you, Prof.
So thank you very much. So can we move on to the second case? Who is presenting?
Hi, Prof. That's Azra here.
Yes.
Unfortunately, I cannot open my presentation. Hold on. So I might need to
Yeah, coming through.
Okay. Then let me share my presentation. It is regarding. Okay. So my case is regarding Madam K, 68 years old lady.
Just now it's 68, now also 68. Yeah? Okay.
Oh, is it? Same age. But a coincidence.
Yeah.
Okay, this lady had underlying systemic amyloidosis with renal and cardiac involvement, as well as multiple myeloma diagnosed in 2012. She underwent multiple chemotherapy, VCD, VD, and later tablet lenalidomide started in November 2017, but withdrew in April 2024 due to pancytopenia. She was then admitted to HKL in early April 2024 for incarcerated hernia, and operation was done on 20 April 2024. However, noted worsening pancytopenia during the admission, and patient is getting unwell. Okay. And the worsening count is mainly on the white cell count. So they do bone marrow examination for investigation of pancytopenia to rule out relapse myeloma, sepsis, or drug induced.
Do we have any idea about the myeloma, whether it is what sort of paraprotein? Is it IgG and then whether it's a compound?
It is IgA lambda. IgA lambda. I only got the serum electrophoresis, and the serum electrophoresis is about 3 something.
Yeah, I think here there's a very important thing to note. If a person has lambda change type of paraprotein, they are more likelihood to develop systemic amyloidosis. So that's why when you do trophine or tissue biopsy, you have to look out for amyloid deposit if it is a lambda change, in this case, lambda change. Yeah, it's IgA type. Okay, sorry for the interruption. Please carry on.
Okay, good information, Prof. Okay, so this is her zero count since January before she's admitted to us on 8 April. During this time, we noted that she already had leukopenia as well as thrombocytopenia, and the absolute neutrophil count is only 0.95. Okay, after the admission, the WBC count is worsened. Okay, up until in May, where the WBC count is only 0.15 times 10 power of 9 per liter, where it's absolute neutrophil count of 0.07. And the platelet also coming down trend, only 20. However, HB is post-transfusion sample, but we noticed that she already had anemia from the admission.
So interesting to note is that when the patient developed pancytopenia, the MCV of the red cell is high, right?
Yeah. Yes. Initially it is high, but with its admission after transfusion, then you know that the MCV is getting disturbed because it's been like somehow replaced by the normal RBC.
So the patient actually has you see the MCV is 114, April 8th. So
on the admission, yep.
Macrocytic anemia with pancytopenia. So we have to do differential diagnosis along that way, macrocytic anemia with pancytopenia. Yeah.
Yep.
Wonder whether that time the neutrophil are hypersegmented.
On that time, we don't have any full blood picture.
Oh, okay.
Unfortunately, during the admission.
The time the WBC is 1.66, but the ANC is 0.19. It's pretty low.
Yeah. But she had the pancytopenia since before the admission itself.
Yeah. The interesting thing is to note that the MCV is very high. So the moment you got a high MCV, you got a macrocytic anemia, right? Severe macrocytic anemia, pancytopenia. There is actually a set of differential diagnoses you have to think of. Yeah. So bear that in mind. Yeah. Okay. Let's continue first.
So let's there is the brief overview about the renal profile and calcium. We can see the range in the renal profile. The albumin is low. Okay, on admission it's only 27 with high globulin lah. Okay, but the ratio is still okay lah. Although that is some sort of reverse albumin globulin ratio actually. On admission there is hypercalcemia.
The globulin is high, is it?
Globulin is high.
Yeah. So did we find out what is the cause of high globulin?
Yeah, that's why first is infection. What they have in their mind is whether it's infection or relapse of their myeloma.
Yeah. So obviously the high globulin make a person suspect whether there is another emergence of paraproteins or not. So at that stage, whether serum protein electrophoresis or analyze whether there is any paraprotein present.
Yep. They also send the serum protein electrophoresis as well as urine protein electrophoresis. However, the result is not out yet when they do the marrow.
All right, good. Let's have a look then, the bone marrow.
Okay.
Maybe you blood film first.
Yeah, I need to change my presentation.
Okay.
Share now. So I need to share the entire screen. Okay, here's my blood film. The blood film is very
not many white cells.
very leukopenic, hardly very few cells in. Okay. Our RBC still looks good, generally nomochromic, nomocytic, but we don't see
this one is transfusion.
Information.
Sorry? This blood film is actually post-transfusion, right?
Yes, post-transfusion sample. That's why we can actually observe like
mainly the transfused cells.
Yeah, because, due to the transfused cells. Agree. There is no renal formation. There is no nucleated RBC.
Okay.
We are not able to appreciate any leukoerythroblastic picture because the white cells are too low. Not able to find any myelocytes. Only very occasional neutrophils, like this one.
How is it like this occasional one? Is it hypersegmented?
No, it's just normal segmentation.
All right.
Okay, let's zoom it a bit.
Toxic or not?
Yes. It's a bit of toxic granulation. But there's only few of them.
Yeah.
Very occasional actually. Higher power. Okay, and the treatment are hardly same. So I think for the FBP, my significant finding is just very occasional neutrophils showing toxic granulation. There is no rulu formation, and there is no polychromasia. Just few spherocytes due to the post-transfusion sample.
So the patient has no spleen. So most likely this pancytopenia is a bone marrow failure. Okay, let's see what is the cause.
Okay.
68 years old.
68 years old.
Hey, got so many cells now.
And right. Yeah, but then the fragments are a bit partially clotted.
Clotted,
a bit partially clotted, but appear hypercellular.
Very,
but the cells are hemodiluted. Okay. And the cells seen are mainly erythroid precursors as well as plasma cells.
Mm. Oh, yeah.
You appreciate it?
That one is a macrophage or is it a plasma cell, so-called Russell bodies?
Those macrophages
Oh,
as
the
well.
macrophages lah. Okay.
We have plasma cells as well as
Wow, so many.
Yeah, so many.
Plasma cells.
They are
Okay, different,
actually
huh?
small size.
There's some big one, like flame,
Uh-huh.
like flame. You see, you got a cluster of more dark staining, but the other one, oh, so purple, violet staining, different, all different types.
Yeah, but majority of them actually are small.
Mm.
Mhm. The one that clustering is actually more towards satellitosis,
But
cytoplatism of
is
the
it
macrophage. Yeah, actually
they're not
surround
macrophages? No,
the
they are not
macrophages.
macrophages. They are plasma cells because the prominent Golgi apparatus.
But there
Essentially,
are
mm,
like leafy cytoplasm actually with recollection here.
yeah, there are all
Cytoplasm
sorts of
leaf
macrophages.
recollection. Yeah, it looks like macrophages on the microscope.
Yeah. Quite a lot of macrophages.
Yeah, a lot of macrophages. Some of them are showing erythrophagocytosis.
Yeah, indeed, indeed.
There's also a few collection of macrophages.
This one, oh yeah, these are all collection of macrophages, lah.
There's also collection of macrophages
Lymphocyte,
with lymphocytes,
lymphocyte. Yeah. When you see this picture, you will think of like what they call
granuloma.
granuloma. You are right. So this looks like a granuloma.
It looks like whether we are dealing with granuloma.
Yes, you may be thinking of granuloma in the bone marrow. Yeah, better look for more.
But only few of collection actually.
Oh,
It also show debris inside the macrophages.
yeah, they are. Don't know whether they are hemosiderin. Are they brownish color? Anyway, you got iron stain.
Yeah, we did iron stain.
That would be nice to look at the iron stain. It will be beautiful.
So generally in the marrow, what we saw is increase in the macrophages, plasma cells, erythroid is present, but hardly see any granulopoiesis and megakaryocyte. So there are significantly reduced granulopoiesis and megakaryopoiesis.
Wow, so many.
It's very interesting.
Full of iron.
Full of iron. But
see whether
in this, this is one of our siderocytes. Our erythroid not able to appreciate. So far, we don't see any
don't see any rings. Okay.
Yeah.
So it's more like macrophages with a lot of iron store inside. Hemosiderin.
Yeah. So let's share the presentation again. Hold on.
You don't have other special stain,
Oh, we want to go to the refine first.
huh?
Can we go to refine first? Refine biopsy.
Okay. Yeah, all right. Yeah, I can see the trifine, whether it's a similar picture. Then you can see more. Yeah, if you suspect granuloma, it's better demonstrated on a trifine section rather than a bone marrow smear. Although this picture, bone marrow smear is quite typical of a granuloma in the bone marrow smear.
Mhm. Okay, but the refine biopsy, we received like 3 pieces of tissue. Okay, generally look normocellular with few areas of hypercellularity. But the marrows, the refine biopsy shows hemorrhagic marrow spaces.
Mm.
So far, I don't see any granuloma.
Mm.
Okay, just the increase in plasma cells as well as histiocytes.
Okay. Do you have any reticulin stain done or not?
Yeah, we did.
The reticulin stain may give you a clue of the granuloma formation.
This one just want to show the plasma cells. There is increase in plasma cells with background of increased histiocytes. And the plasma cells are interstitial located interstitially, and they are small size, mature looking.
This is a blood vessel, right? The one there's an indicator that is a blood vessels, huh? Can see the blood vessel wall. Is there any amyloid deposit still?
No. From
No,
our
eh?
combo
Normally you
staining.
see in the arterial wall. Yeah, this is a small
The
mini.
wall not thicken as well.
Mm.
Just the normal thickness of the vessel.
Yeah, it's a very small blood vessels.
A bit okay. As for the reticulin stain, we are not really able, there is no increase in
Mm.
reticulin. However, the marrow is hemorrhagic, so there is some
Some reticulin doesn't form any pattern.
no pattern.
Yeah, no pattern to describe a granuloma. Well, I suppose you got only so small section now.
But this one,
These are all very hard.
one, no, just like grading of 0 to 1, not particularly see the pattern that highlight granuloma.
Yeah.
Yeah. So that's all about the reticulin.
There are certain area quite interesting, the reticulin pattern. Yeah, very hard. Doesn't really form a outline a granuloma.
Yep. Mainly just the vessel.
What is about that area?
Vessel.
That one doesn't next to the trabeculae. What is that? That area. Small aggregates of cells here. What is that?
This one.
Yes.
Erythroid.
Erythroid, is it?
Yes.
They are all erythroid.
Yeah, it's abnormally located to paratrabecular area. But we will see our E-cadherin here to confirm this cell identity. But morphologically, it looks like erythroid.
Okay.
Because it's nice round cells. I don't use glycoporine A because of hemorrhagic marrow, so I don't want any interference by the red blood cell.
Okay.
So this is my E-cadherin. So we can still see a good erythropoiesis in collection in islands, both in the central part as well as the paratrabecular area.
There's a normal distribution of erythroid cluster.
Except there is few located at the paratrabecular area. Usually we expect it to be at central.
Yeah, it's very unusual, isn't it? Yeah.
Yeah, but we
It
can
should be
expect.
interstitial.
Okay. Let's go to our plasma cells. Since we saw increase in plasma cells on the treatment as well.
See how it distributes itself?
Okay, this is MUM1.
MUM1 for macrophages.
But in this case, it's for plasma cells.
You are doing it for plasma cells.
Post-terminal center B cell. Yeah. And if you can appreciate the morphology,
doesn't form cluster.
You can see it didn't form cluster, mainly singly distributed. And as you can see, the cells are actually small, eccentric nucleus. And the thing actually staining the nucleus of the cell.
So many plasma cells.
So many plasma cells. So approximately about 40 to 50% of total nucleus cells. Okay. But they look mature looking.
Mature looking, yeah, they are.
We also do 138. But with 138, in terms of percentage, it look higher in percentage.
Yeah.
So I personally preferred MUM1 to count my percentage of plasma cells. So
It's the more primitive one, I suppose.
138.
Yeah. Why? That's why it's staying so many. More immature one.
Okay. 138 is positive. Let's see our kappa and lambda.
Let's see kappa and lambda.
Our kappa and lambda had background staining.
Definitely one.
Especially with the hemorrhagic sample, it is waste-like actually.
Not easy.
It's not easy, but we can see there's pickup for the kappa stain.
Stronger. see.
Yeah, the strongest cytoplasmic staining, but there's also cells without any, which did not pick up the stain. Okay. So kappa is positive. Lambda is also showing similar finding.
A lot of background staining lah,
Yeah.
both lah. But in terms of intensity, stronger for kappa rather than lambda lah.
Actually both are strong. See? Both are strong for the
Are you
positive
able
lambda
to-
staining.
Are you able to count them? What is the ratio like?
No.
No, difficult.
Yeah. Yes, a bit difficult. But generally, glance through, it just looks like 1-to-1.
Could be 1-to-1 lah, yeah.
No,
Okay.
could be just 1-to-1.
1-to-1 ratio.
Yeah.
Okay.
Okay. So we also do CD68 to highlight
Okay.
our macrophages. Since we
Yeah,
have
it will be very useful. Let's see what is the pattern like.
okay.
Wow,
Okay.
many
There's there's a lot of histiocytes. There is no absolute presence in collection, but since we do see collection at the aspirate, and
How
there is no granuloma.
How
so
does
we
it
also
relate
do-
to the plasma cells, all this staining?
Sorry, sir?
How do the macrophage staining relate to the plasma cell distribution?
Like
It looks like, yeah,
the same.
pattern.
Different.
Do you think there's a pattern? Like you see here, you notice the plasma cell is around the macrophages. Yeah, you do see a pattern. Let's see. Although the H&E doesn't show granuloma formation, your special stain with plasma cells and macrophages do look like there's a pattern, you know. Don't know, you have a look at it, see whether it's a pattern. They are actually surrounded, they are actually like, not really aggregates of macrophages, association of macrophages together. And then you see some plasma cell distributing among themselves. I think there are also some lymphocytes also. Yeah. So it actually give you a picture of a diffuse type granuloma from the not evident in your H&E, but if you add all the histochemistry overlap together, then you may actually see a diffuse pattern type of granuloma formation. That's how I look at it.
Prof. Okay. Never aware on that, Prof.
Oh, no, I had seen this before. I think, yeah. Yeah, so you have to start thinking about granuloma infection in the bone marrow. So you think about syphilis, TB, you know. Yeah.
Yeah.
Those are the...
So we did our ZN is negative.
Negative, okay. Yeah.
No acid fast bacilli.
Yeah.
And then our fungal stain also not showing any fungal bodies.
No fungus, Don't know whether they have tested syphilis or not, VDRL. Yeah.
I'm not sure on that.
I think those are the things you have to think of, like granuloma formation. Yeah. Diffuse. This is more like a diffuse pattern of granuloma with reactive plasmacytosis.
I see. I thought it's supposed to be collection. No, collection of epithelioid cells. Epithelioid
The macrophages are the
granuloma.
epithelial cells, no? The epithelial cells are
yeah,
actually
but it's
specialized.
supposed to be epithelioid. No. No, it's supposed to be rounded a bit to form granuloma.
Anyway, those are staining characteristics. I mean, they are
I see.
pictures. So once you have to actively think about granuloma infiltration of your bone marrow with reactive plasmacytosis. Yeah. Interesting.
Yeah. Our AFB staining is negative. The nascent AFB is negative. We also send marrow for TB culture. It's negative.
Fungal?
Fungal also negative
Oh,
culture.
yeah. Okay. Have to lah, because I think they still have clinically still have to go and search for granuloma infection.
Okay.
I have to, since they haven't actually looked at syphilis, now there's a resurgence of syphilis cases. So definitely have to think about syphilis infection.
Okay.
Okay. Any more?
This one is for the Congo rate.
Okay. Let's see whether we can see anything. Congo rate to find some amyloid on the blood vessels.
Okay, for Congo rate, first we see and H&E first.
Soft tissue.
For Trifine, it is our control tissue. It does presence of any amyloid. The color supposed to be brick red. Not sure whether you are able to appreciate the brick red in color.
Oh.
Macam merah bata lah dia punya
yeah.
Color of the staining.
This one is stained with Congo red. Yeah.
Correct. Yeah.
Okay. I suppose you can show your polarized light or not.
There is no polarized light, but with this under normal light microscopy only.
Yeah.
First, we need to see this the red color. This red color area.
Okay.
Then only we can focus on the polarizing. As for the Trifine, we don't see that red color.
Yeah, the control you can show it lah.
Yeah.
For the Trifine, you don't see anything.
And on the Trifine, we don't see any brick red colored area.
So
but we also see under polarized. And it's negative.
Negative, yeah. Not surprised lah. Because there isn't any blood vessels inside other than some tiny capillaries and venules. Normally the deficit is the arterial blood vessels. Of course, very serious cases, you can see tissue deficit of amyloid.
Okay.
So, interesting. Yeah.
Okay, let's go back to our presentation.
All right.
Hello. Okay. Are you able to see my presentation? So immunophenotyping of the marrow aspirate showed 45% plasma cells. We gated at CD38 positive cells. And we're able to see that the population is for CD45 intermediate with moderate size scatter. They are positive for CD138. And the kappa and lambda is showing equal distribution.
Yeah, 1-to-1. Okay.
CD56 is negative and B2M is positive. The infraction is bone marrow RT shows reactive plasma cells with normal kappa and lambda distribution with no aberrant marker, not suggest of disease relapse.
Okay. So they still have to find out what is the cause of the pancytopenia lah.
Yep. So correlating with the IPC, the marrow finding are maybe due to infection, inflammation, or drug related. Okay. Our serum and urine protein electrophoresis showed no paraprotein band and no immune paresis.
The serum immunoglobulins are level are normal, is it?
Serum immunoglobulin level, is it?
Yeah, I presume that's how they
Yeah.
no
There
immune
is no immune paresis.
all the immunoglobulin IgG, IgA, IgD, all these are normal lah. But definitely there's hypoalbuminemia lah.
Yes, during this admission.
Okay, so that's support saying that this patient has no relapse.
It's not relapse. Okay. So serum free light chain is also normal. CNS, most of the culture show no growth. And MTB culture is negative. Fungal culture is also negative. They had occasion of Enterococcus faecium and Klebsiella species growth in May 2024 after we did the marrow. Okay. So as our final impression, so the marrow as well as refined biopsy showed reactive changes with significant reduction in granulopoiesis and megakaryopoiesis to exclude infection, inflammation, or drug related. And there is no evidence of relapse multiple myeloma. So this discussion part already, Prof. So generally for this case, it's benign polyclonal plasmacytosis. The causes is mainly infection, chronic infection especially, viral, fungal as well. Inflammation, liver cirrhosis, and drug reaction, as well as other hematological malignancy like T-cell lymphoma. Morphology, usually in benign polyclonal plasmacytosis, there's rouleau formation due to increase in concentration of polyclonal immunoglobulin, but we do not see it in this case. There is increase in plasma cells. Usually it's not exceed 20%, but in this case, it exceed almost 50% plasma cells. But in reported cases, there's cases actually had more 50% plasma cells. And the plasma cells have mature nuclei. For the refined plasma cells, usually located at interstitial and pericapillary, and it may have reactive lymphoaggregates, and as well as increase in eosinophils, mast cells, or macrophages. Like in this case, we saw increase in macrophages. And the trifine may also show small clusters of plasma cells. That's all, Prof.
Okay, so thank you very much. Yeah. Any comment from the participants? Is there any case similar that you have seen before? Where such an intense reactive plasmacytosis.
Yep. We are afraid that we are dealing with relapse actually. Although when we saw the marrow aspirate at first time, initially when we saw it, it looks reactive because of this plasma cell is not mature looking. It's not really abnormal looking.
Correct. I think the important point to point out to everybody is that not only they are matured looking, but there are different varieties of plasma cells. That is typical in the reactive plasmacytosis. Yeah. So that's a very important take-home message.
Okay.
So additional thing like Flo is just to help you to say, yeah, pretty sure you at the end of the day of the investigation, you are confident to tell the clinician saying that no, there's no relapse of multiple myeloma.
Mm-hmm.
But then the other thing is that we haven't helped them, what is the cause?
Not actually found the cause of the infection.
Yeah.
They actually covered the antibiotic that they gave actually covered the organism that been cultured. But with time, the patient has been admitted for 4 months already. For almost 4 months already. She's still admitted at in ward. But she's already outside the ICU.
Okay.
Her count generally WBC normalized already. Platelet is slowly picking up. Now it's 107.
Is the patient still febrile or something like that? No?
I cannot get that history.
Oh, okay.
Yeah.
But certainly, I think a good suggestion after this meeting is to find out whether they have actually excluded syphilis. Secondary syphilis. Yeah, something like this. Secondary syphilis. Yeah.
Okay.
When they are in the second stage. Primary stage we call Schenker. Then they go into secondary stage. Tertiary stage is, of course, then granuloma and things like that. Yeah. They will go into systemic cardiovascular, etc. So when you have a secondary syphilis, it may actually affect the bone marrow in this way. Yeah. But there's history. But it's good because it's a treatable condition. Suggest to them. Okay.
Okay. We will check back the VDRL and TPPA results.
Yeah.
Okay. But as for the granuloma, Prof, the diffuse granuloma.
Yes.
Okay.
You can check. I think the bone marrow smear is highly suggestive of granuloma. Whenever you see it, always think of granuloma. Then bone marrow, of course, H&E doesn't give you the typical picture because again your fragment of traphi is so short, only a few. So it may not be representative. But definitely the way the cells distribute themselves, I was looking at it, with a plasma cell, the lymphocytes, the histiocyte, very, very highly suggestive. Actually got a diffuse granuloma type of reaction. Yeah.
I see.
Okay. So I think that's all for today. So thank you very much for the HKL team. Wonderful, very nice case. And the second case is interesting because we have got big doses of cancer, blood malignancy. Today we have a benign condition. Good. So thank you very much for a change.
Okay, thank you very much.
Thank you. Have a nice day.